this is kind of the new frontier, making pretty people feel as good on the inside as they look on the outside. It's not a fad. GLP-1s are not a fad. Peptides are not a fad. Now maybe not every peptide is going to be around forever, but there's some that people are swearing by. And it's like, eventually there'll be better studies. But right now, there's just not really good clinical evidence.
I am here live with Dr. Jonathan Kaplan, who's also the CEO of DrWell and founder.
Yes.
I'm so happy to have you in the podcast today, live at the Aesthetic Meet. Welcome.
Yeah, we're happy to be here. It's been actually a great few days. We had our DrWell corporate retreat here in Boston for the last few days, obviously leading right up to the Aesthetic Meet. And we did it over at the Four Seasons. It was pretty fancy.
Oh, that's nice.
Yeah.
I like it.
So we had a great retreat. We had some great speakers, including myself, and but also we went to the Boston Red Sox game last night.
How was that?
It was great. The rain held off, and it was like this just nice, cool weather. The Red Sox lost, but for us, the purpose was to go to Fenway Park.
Yeah.
It was incredible.
It's the purpose of Fenway Park. You don't have to be a Red Sox fan to go.
Exactly. So no, it was a lot of fun. We got some merchandise, and so I have something to take home to the kids.
Were they playing Philadelphia?
Philadelphia, exactly.
Yeah.
And actually, one of the speakers at our retreat is this guy, Dr. Stephen Klein. He's a addiction medicine specialist, and he's one of the people that's on the forefront of using GLP-1s for alcohol use disorder. He came and spoke at the retreat. We're doing some collaborations with him and working with him to get an investigational new drug application with the FDA for our GLP-1 squared combination of semaglutide tirzepatide. Anyway, he's from Philadelphia. He flew in from Philadelphia yesterday morning to speak at our retreat, and he showed up to the game in a Phillies jersey, and they won.
That is beautiful. I love it.
So,
speaking of GLP-1s, let's talk about all the recent 503A, 503B drama.
Yeah, so for the 503Bs, that's the pharmacies that are able to make bulk compounds of medication, when there's shortage, when there's not shortage. When there's not a shortage, they can make like bulk compounds of like generic drugs. But if there is not a shortage, then they're not allowed to make commercially available drugs.
Correct.
And so that's why with the 503B pharmacies, which are the ones regulated directly by the FDA, really have no legal pathway to have been making the GLP-1s since the shortages ended, over a year ago.
Yeah.
And the FDA, I guess, the FDA was busy with a lot of other things, but then they finally have reached out to several of these 503B pharmacies and let them know that you got to stop doing this. And so ProRx, BPI Labs, which are the big, two of the big ones that I've heard of, they had to stop making GLP-1s. And so now everybody's rushing over to work with DrWell to find because we have access to 503A pharmacies that are legally allowed to make alternative personalized formulations of GLP-1s. So still can't make the commercial you can't make a copy of the commercially available ones.
Got you. So 503Bs are out, 503As
still
they were always in.
Yeah, they're still in. They're still in, and so that's why you can see them getting formulations with B12 or B6 or glycine. People talk about how they're personalized, and I think it's probably better to say they're customized, because personalized is a little, I feel like we're lying to each other. You're not personalizing 100,000 doses of medications for your patients.
Right.
But the thing is, it is a very legitimate, bona fide reason that with one of the ways GLP-1s work is delayed gastric emptying. So there's some less absorption of B12, B vitamins, because intrinsic factor isn't released adequately, or it isn't able to bind adequately to food because of delayed gastric emptying. So there's a potential for people to have a B vitamin deficiency. So that's why you add it in as an injectable with the medication. People are worried about lean body mass loss with GLP-1s. Everybody knows about that. And so that's why you add glycine. It minimizes lean body mass loss. Or you just really work out. That's one way to minimize lean body mass.
It's funny because GLP-1s, everybody talks about the side effects of GLP-1s, and I'm like, they're just the side effects of massive weight loss, right?
Correct.
All of these things, it doesn't matter if it's a GLP-1. It just happens to be that GLP-1 leads to massive weight loss.
Correct.
But if you did gastric bypass surgery or something else and you had massive weight loss in your life, or you just went really hard on your exercise and diet and had a massive weight loss, the side effects are going to be the same.
No, I agree. And one of the ones that's really mostly associated with GLP-1s is like blindness, that really rare NION, which is the non-arteritic anterior ischemic ophthalmic neuropathy, NION, N-A-I-O-N. That is been associated with GLP-1s, but the truth is that's really similar, and it's not the same pathophysiology, but it's similar to diabetic retinopathy in that as people's sugars get better controlled, they have an increased risk of diabetic retinopathy and that NION. So better control. So you think, oh, your sugars are getting worse control. Why wouldn't they get it? Anyway, it's opposite of what you think. But even even semaglutide, or what's the people are associated with Nion, even that is really something about controlling your sugars better, is leading to some of those ophthalmic issues. However, keep in mind that even that one, Nion, is like 0.2 to 0.4% over 20 years if you have type 2 diabetes.
Yeah.
So it's extraordinarily rare.
Exactly.
Anyway, but so yeah, and going back to your point, it really is associated with just massive weight loss and controlling your sugars.
Controlling your sugars.
Yeah. So, but that's what's going on with the 503A, 503B. But the big talk, and I just did a course about peptides.
Mm-hmm.
And before anybody thinks I'm like one of these influencers that's like talking about, oh, you got to do BPC 157, Jim bro. The thing I always say is that with peptides, at best they work, at worst they do nothing. And
I
so
couldn't agree more.
I don't think they're dangerous. They're, there's these, peptides are really proteins, but people are now just associating these short chain amino acids as being a specific type of peptides that replicate some of the normal processes in your body, like NAD or BPC 157 is found in stomach acid. It helps with wound healing. And I think that's one of the reasons the FDA is evaluating it now to make it compoundable again.
Yes.
And they've taken it off the category 2 list, which means which says you can't compound it if it's on the category 2 list. They've taken it off of that. They haven't put it on the category 1 list, but because there is this upcoming PCAC meeting in July where they're officially going to move it over to category 1 theoretically, because RFK Jr. is a big fan of peptides, that some of the 503A pharmacies we work with are taking the calculated risk, saying that, okay, they've taken it off category 2. There's not going to be an enforcement. We're going to make peptides. So now DrWell is able to source peptides, non-research grade, from 503A pharmacies for our providers. So that's been exciting.
Which I think is great, because there's a lot of peptides out there. So when somebody asks me how I feel about peptides, how do I answer that question?
Exactly.
Right?
You got to try it.
You got to try it. And there's also some that I cannot attest to. I've not tried, or I've not seen others try, and might do nothing, or might be a waste of your money, or might not be. But I could take something like BPC 157. Now, I haven't personally tried it, but I do know of several people who have.
And they swear by it.
And they swear by it. And of those people, they typically, I would say, are 40 and up.
Yeah.
And it's some sort of athlete of some sort. Maybe not an athlete is an overstatement, but they at least go to the gym. They had a bum knee. They had a bum ankle. Right. They had something that wasn't physically great, right?
Yeah.
And they swore by the BPC for that ankle or that knee, that,
I've
sore
used
back.
it, and I'm like into boxing, kickboxing. I go, a couple days a week with a personal trainer. I'm also doing like hot Pilates, yoga, and things like that. And I would say that with the BPC 157, and if you combine it with TB 500, that's the Wolverine
that's
blend.
The Wolverine, yes.
That I feel like maybe my muscles are not as sore the next day.
Right.
I'm able to work out 5-6 days a week and not as sore. And then with NAD, I feel like that raises my energy level when I'm working out, that I can be in maintain a higher level. Now, is it placebo? Is it just in my head? Maybe, but I know that it's not, as far as I know, it's not making me like sick.
It's not making you sick. And also, I'm just going to say something. There's nothing wrong with the placebo effect.
There's nothing wrong with the placebo effect.
It is very validly and medically shown that how you are psychologically, mentally, it can affect your body. It can make you heal. It's a magical effect.
And with this audience that we're with at today, the aesthetic meeting, the aesthetic plastic surgeons, that if your whole career has been about making people pretty on the outside, this is kind of the new frontier, making pretty people feel as good on the inside as they look on the outside. And so I definitely think it's not a fad. GLP-1s are not a fad. Peptides are not a fad.
No.
Now, maybe not every peptide is going to be around forever, but there's some that people are swearing by. And it's like, eventually there'll be better studies. But right now, there's just not really good clinical evidence.
No, I don't think it's a fad at all. I remember a lot of people when GLPs were first getting popular. Not first getting popular. They've been around for a long time. Let's just say for weight loss.
I understand,
Okay. I knew a lot of people who thought it was a fad. And I, from day one,
you knew it.
Like, absolutely, this is not a fad. So did you?
I was totally knew it.
This is huge. This is arguably, and some people might disagree, our next antibiotics. I mean, obesity causes.
I've always said it's bigger than penicillin.
Yeah, it's either bigger or it's the biggest medicine since penicillin. At least that.
The reason I sort of jokingly say it's bigger than penicillin is that penicillin was only good for bacteria.
Yeah.
GLP-1s are good for reducing cardiac risk factors. It's good, obviously, for reducing your appetite. As I've talked about, it's going to be going to get indications for alcohol use disorder and other like even like maybe meth addiction, other addictions. So it's and the fact it's chronic kidney disease. Fatty liver.
Well, because it fixes the visceral fat, right?
Yeah, so that's interesting. That's an interesting thing that's coming out about a peptide is tesamorelin, and however you just wanted to. That actually is a peptide that's actually got FDA approval behind it.
Interesting.
And it's for HIV lipodystrophy. So people with like fatty, like visceral fat, what you're talking about on the inside around the intestines, depending on what audience is listening to us. Tesamorelin is FDA indicated for visceral fat. So people who are losing weight on GLP-1s, they still may maintain some of that visceral fat. Other people, it may take care of it. But that's one of the stacks that we're now offering. With DrWell, we just revamped our entire platform. It's like this beautiful, it's a work of art. And what we've done is we've really focused on making it possible to do more stacks, meaning that you send a patient a link, they pay for a stack that includes a GLP-1, BPC 157, and tesamorelin for visceral fat, and maybe Hair Force 1. So 4 different medications. You send them a link, they pay once. And what happens is that auto generates 4 different prescriptions in the back end of the DrWell system. Then the provider logs in, submits those 4 prescriptions, and they're distributed to 4 different pharmacies potentially, because you might be in a state where only that pharmacy can ship it to you. So that's something that people cannot do with an EMR or whatever.
Absolutely.
So anyway, so that's something we're doing more of is tesamorelin for visceral fat in addition to their GLP-1.
Wow.
So that's, and again, I love an FDA approved drug, because then I don't feel like, yeah, exactly. I don't feel like I'm selling snake oil. And I love the data. And even if people have a distrust of the FDA, that's fine. But I would have, but there's one thing to be distrustful of the FDA that does all of this research versus why go the opposite direction and have distrust and then trust something that has no data.
Yes. I couldn't agree more. You know, one thing, this is a little bit of I don't know if it was a debated topic. I'm curious what you think. Do you feel, and I've talked to a lot of different plastic surgeons, a lot of different medical providers, because obviously not just plastic surgeons that do GLP-1s or provide them. Do you feel that GLP-1 always has to be a life commitment?
So that's really interesting. That was the first thing I thought of when you said that people were thinking GLP-1s were a fad and knew from the beginning. One of the things I felt like I knew from the beginning is that people are really too preoccupied with whether you take it for the rest of your life, because I think people were just thinking about it in the terms of weight loss.
Yes.
And so while I maybe for weight loss, maybe you don't need to take it forever, but I think that's not necessarily, shouldn't have to put that kind of undue risk on yourself thinking, I got to get off in 6 months. You may take it forever for weight loss, but you might not necessarily have to take it every week for the rest of your life. But in addition to that, the cardiac risk factors, the fact that we're taking aspirin a day, which that is not even recommended as much anymore. So I do think that people will choose to take these the rest of their life, but not just for weight loss. I think there's, while one study came out about semaglutide not actually working that well for Alzheimer's, that was oral semaglutide, and they didn't it wasn't injectable.
For sure.
So I think people will be taking it for many more other things for the rest of their life and choosing to.
I think you're right. I think it depends also on what caused them to need the weight loss, or what got them to the GLP-1 in the first place. Like, you're my GLP-1 doctor. I know you can't say anything hip. I'll happily say that, right? And I liked how you dose it, because you dose very much based off the person and where they're at. But for me, I got pregnant. I gained 75 pounds with pregnant. As soon as I was done being pregnant, I wanted to lose the weight real fast, right? Yeah. So I used the GLP-1 to lose the weight real fast, but I don't still take it, right? I have what I call emergency dosage in my fridge, right?
I love that.
And I think
break the glass.
yeah. I took my last emergency dose was after Christmas. Right. So Thanksgiving, Christmas, I did a little 2.5, but that, we're now in May.
Yeah. It's 5 months ago.
Yeah.
Exactly.
And I would say last year probably was similar, where there was maybe once a quarter or once every 6 months or so, an emergency dose here or there. And for me, like I said, and I know you pretend as a doctor you don't hear any of this, because I just keep the vials in my fridge, and maybe some of them are expired, and I dose myself at this point. But I have the materials, right? That's on me. It's not anybody else.
And that's definitely something I think we're getting past, to think that you have to go up and dose every month. I know that's the name brand drug regimen, but yeah, people are definitely, it's the coolest drug in that sense, because you're so used to your doctor saying, okay, like take this medication, this off, and this dosage, like, take 2 Tylenol. But this is so personalized. People know it. They get this personalized, they get this very intimate relationship with their GLP-1, and they know what their body needs or doesn't need.
Because somebody would argue that you can lose less weight at too high of a dose too. It's such a funny thing. It
Yeah.
really depends on your own body. You find a sweet spot and you're like, okay, that's my sweet spot.
It's
And that's what it
incredible.
be. And that's why I've never been, I'm a fan of telehealth, don't get me wrong. But if there's not like a bit of personalized care that goes into it, so
Sure.
not like the huge big brands, because there's no personalized care that goes into that.
Definitely not. It's not their business model.
It's not their business model. But for telehealth, for a practice like yours or DrWell, like that's fantastic because there does need to be some personalization. There needs to be some communication back
Yeah.
and forth because, you
Well,
know,
that's exactly what we're doing is we're taking that technology stack that makes it so easy to enroll with a DTC
Yes.
platform, but putting it in the hands of providers because you're not going to go out and build that technology.
No.
So we're basically allowing you to, we're leveling the playing field so that your customer service interface is as good and as slick and as easy to enroll as the DTC platform. But of
Yes.
course, they're connected with an actual medical
and
practice.
that's the way to do it. And that's, you know, I definitely, you know, everybody has friends, family, et cetera, at GLP-1s at this point, right? One
Absolutely.
in 8 Americans, which is wild, right?
It is.
I'm always like, no, Ro, no his and hers, because they're not going to help you get your dose right.
And also-
sometimes you have to you don't want to, as much as we like to rapidly lose weight, there is a health concern about, are you getting the amount of protein and nutrition you need? There is a certain point where like the deficit, ultimately it's a calorie deficit, right?
Right.
But there's too much,
But
right?
people forget that the way these really work best for your entire lifespan, health span is working out, eating a high
Exactly.
protein diet. So there's definitely those reminders that you get from your medical practice, your provider.
Exactly. And making sure that you eat the protein to help at least the muscle loss is going to happen. And
By the way, you
build it.
mentioned pregnancy, and I don't not to get into whether you were taking it before or after pregnancy, but that's fertility specialists are starting to recommend it ahead of time because it's improving the quality of the egg and the number of eggs.
I
It's
agree.
really fascinating.
I have an argument that is not no OB is going to back me up on this. Every one of them is going to say, no, you need to stop it before. I personally think you should take GLP-1s until you find out you're pregnant. Meaning a lot of doctors are out there telling you to stop them 3 months, 6 months, et cetera, before they tell you to stop before you start trying.
They're basing that on animal studies, and they don't
Yes.
have they don't have any prospective human studies, which of course they're not going to have
They're
a
not gonna
prospective
have.
study. But
Yeah.
I believe there is actually enough retrospective data now showing that all these
Because of
people,
all those Ozempic babies.
all the Ozempic babies, they got
Mhm.
pregnant because they didn't think they were, well, Ozempic baby can mean two different things. It can be either because you got pregnant because your birth control pill wasn't effective because of the
because
delayed
Ozempic,
gastric
yeah.
emptying. But the truth is what I've found to be more common is that they weren't on birth control because
Correct.
they thought they were infertile, but it was really due to obesity. They were losing weight. They became
Mhm.
more fertile. And so there's enough retrospective data now, I would argue, that shows that all the people who got pregnant by being on a GLP-1, and then once they stopped in that first trimester, that there's definitely clearly no statistically significant increase in major congenital malformations. So,
I think so too. I would, like I said, I would argue that you don't need to stop it until you find out that you're pregnant. I would almost slightly argue that it's not the end of the world to use in your first trimester. I don't know. Now I'm talking about something that's really controversial.
Right. But the other thing that makes it less controversial is that the FDA has already come out and said that if you're taking a GLP-1 for type 2 diabetes,
That's right. It's okay.
that it's okay, but if it's a discussion between you and your provider, but they absolutely didn't say you've got to stop it. It's for
No.
type 2 diabetes. So that reminds me a little bit of the breast implant fiasco
Mhm.
in the 90s. We can't use this because connective tissue diseases. While the whole time they were allowing people to use silicone implants in breast
Right.
cancer reconstruction.
Yeah.
They're essentially saying, oh, well, you've got cancer, so it doesn't matter if you get lupus. So this is the same kind of thing that
Yeah.
if they're allowing it for type 2 diabetics, that they're obviously making a risk-benefit ratio determination. But if they were causing tons of major congenital malformations, they would have
stopped.
stepped in. They would have stepped in and stopped it.
Yes.
Exactly.
Yeah. This is not Accutane,
Right. Exactly. No. Oh wow, that's a great comparison. That's a
It's-
great comparison.
Right. It's just not.
That's when you definitely don't do that.
You don't do that.
You don't do that.
Well, man, we could talk forever, but it's been so great having you on, and we're definitely gonna get another webinar in the books we'll get one on the books.
Looking forward to it.
We'll do it. All
That's
right.
awesome. Great talking to you. Thanks
Great
for having me.
talking to you. Okay, bye.